Let's talk about measuring HBV DNA to guide treatment eligibility and monitor the response. We use laboratory-based HBV DNA assays. Directly following a positive hepatitis B surface antigen serological test result, the use of HBV DNA nucleic acid testing (NAT), quantitative or qualitative, is recommended as the preferred strategy to assess viral load level for treatment eligibility and monitor treatment response. New recommendation point of care (POC) HBV DNA assays are included. NAT assays may be used as an alternative approach to laboratory-based HBV DNA testing to assess HBV DNA level for treatment eligibility and to monitor treatment response. Assays should meet minimum quality, safety, and performance standards. Now for HBV DNA reflex testing. New recommendations are available. Where available, reflex HBV DNA testing for those testing positive on hepatitis B surface antigen may be used as an additional strategy to promote linkage to care and treatment. This can be achieved through either laboratory-based reflex HBV DNA testing using a sample already held in the laboratory or clinic-based reflex testing in a healthcare facility through immediate sample collection following a positive hepatitis B surface antigen rapid diagnostic test (RDT). For hepatitis delta virus HDV testing. Who to test? For people with chronic hepatitis B, serological testing for anti-HDV antibodies may be performed for all the individuals who are hepatitis B surface antigen positive as the preferred approach to scale up access to HDV diagnosis and linkage to care. In settings in which a universal anti-HDV antibody testing approach is not feasible because laboratory capacity or other resources are limited, testing for anti-HDV may be given priority in specific populations of hepatitis B surface antigen positive individuals, including the following: people born in HDV endemic countries, regions, and areas, people with advanced liver disease, those receiving HBV treatment, and those with features suggesting HDV infection, such as low HBV DNA with high ALT levels, and people considered to have increased risk of HDV infection, including hemodialysis recipients, people living with hepatitis C or HIV, people who inject drugs, sex workers, and men who have sex with men. How to test for HDV infection, testing strategy, and choice of serological and NAT assays. People with chronic hepatitis B, which means hepatitis B surface antigen positive, may be diagnosed with hepatitis B by using a serological assay to detect total anti-HDV, followed by an NAT to detect HDV RNA and active infection among those who are anti-HDV positive. Assays should meet minimum quality, safety, and performance standards. The NAT for detecting HDV RNA should be harmonized with the WHO HDV RNA standard and the results reported in International Unit per ml. The assays should have a limit of detection of 100 IU per ml or better. Primers used in in-house assays should target the ribosome region, which is the most conserved region of the HDV genome for genotype inclusivity. How to test for HDV infection? Laboratory-based reflex testing. Reflex testing for anti-HDV antibody testing following a positive hepatitis B surface antigen test result, and also for HDV RNA testing where available following a positive anti-HDV antibody test result, may be used as an additional strategy to promote diagnosis. Monitoring for treatment response and surveillance for HCC. 1. Monitoring for treatment response among people with chronic hepatitis B receiving treatment or not yet receiving treatment. For people receiving treatment, the following are recommended to be monitored at least annually. Non-invasive tests, APRI score or transient elastography to assess stage of disease and progression of fibrosis or cirrhosis, and ALT levels and AST for APRI, HBV DNA levels when HBV DNA testing is available, hepatitis B surface antigen, hepatitis B envelope antigen, or anti-HB. Treatment adherence should be monitored regularly and at each visit. More frequent on-treatment monitoring every 3 to 6 months for the first year may be performed for people with more advanced disease, compensated or decompensated cirrhosis during the first year of treatment to assess treatment response and adherence where treatment adherence is a concern. In HIV-infected people and for people with renal impairment. Now for monitoring for people not yet receiving treatment. People who do not currently meet the criteria for antiviral therapy, persistently normal serum aminotransferase results and HBV DNA levels below 2000 international unit per ml when HBV DNA testing is available, or who have expressed a desire to defer treatment may be monitored annually for disease progression and ALT and HBV levels. ALT levels fluctuate among people with chronic hepatitis B, and longitudinal monitoring is required to determine the trend. The ULN for ALT has been defined as below 30 units per liter for men and boys and 19 units per liter for women and girls. Persistently abnormal or normal may be defined as 2 ALT determinations above or below the ULN at unspecified intervals during a 6 to 12 month period, or predefined intervals during a 12 month period. Among people receiving treatment, monitor for hepatitis B surface antigen loss, although this occurs rarely, and for seroconversion to hepatitis B surface antigen positivity after discontinuing treatment. Quantitative hepatitis B surface antigen, if available, can be used to determine whether hepatitis B surface antigen concentrations are declining or more rarely seroclearance. Monitoring of hepatitis B antigen and anti-HBe mainly applies to those who are initially hepatitis B antigen positive. However, those who have already achieved hepatitis B antigen seroconversion and are hepatitis B antigen negative and anti-HBe positive may subsequently serorevert. Decompensated cirrhosis is defined by the development of portal hypertension, ascites, variceal hemorrhage, and hepatic encephalopathy, coagulopathy or liver insufficiency, jaundice. Other clinical features of advanced liver disease or cirrhosis may include hepatomegaly, splenomegaly, pruritus, fatigue, arthralgia, palmar erythema, and edema. Now for monitoring the safety of nucleoside analogues. Before initiating antiviral therapy, people's baseline risk for renal dysfunction and measurement of baseline renal function may be performed. People receiving long-term tenofovir disoproxil fumarate therapy may be monitored annually for renal function and growth monitored carefully in children. Note, in the 2021 WHO Consolidated HIV Guidelines, baseline measurement of creatinine is not required before initiating ART for people living with HIV with the preferred tenofovir-based regimen. Factors associated with a higher risk of renal dysfunction include decompensated cirrhosis, creatinine clearance below 50 milliliter per minute, older age above 60 years old, body mass index BMI below 18.5 kilogram per meter 2, or body weight below 50 kilogram, poorly controlled hypertension, proteinuria, uncontrolled diabetes, active glomerulonephrititis, concomitant use of nephrotoxic drugs or a boosted protease inhibitor for HIV and solid organ transplantation. Measurement of baseline renal function includes serum creatinine levels and calculation of creatinine clearance, estimated glomerular filtration rate, eGFR, using the Cockcroft-Gault, CG, or MDRD formulas. An online calculator is used. For treatment for acute hepatitis B virus, there is no specific medication to treat an acute hepatitis B infection, and many people won't need any treatment, but if you're having severe symptoms, a healthcare provider might monitor you for complication and offer supportive care such as IV fluids, IV nutrition, and pain relief.